surgical psychotherapy. Every time you do a good blepharoplasty, it's surgical psychotherapy. And sadly, it's not just the patient who looks good. They want to be seen as looking good by their friends, their neighbors, their children, their spouses. And the worst complication I've ever had was a patient who told me, "You've done such a good job, Dr. Ganga. The patient does not notice any difference. He's not made any compliments." So never look at the feedback from the husbands, but from other ladies.
يعني actually when they have a social commitment, like they have a wedding in 2 weeks or have attend whatever purpose for their son,
And no pressure on the surgeon, right?
Okay.
I have ladies who come and say, "I'm getting married on Saturday." They show up on a Monday and said, "Can you do it for me today, tomorrow?" So
Yeah, that's right. Yeah, that's.
Yes.
I just had two patients saw last week, and we had weddings in 4 weeks. So
Yeah. So we are coming to a very important talk, which is commonly not addressed.
I've already lost a minute and a half.
It's okay.
on my-
Now just hang on for a
Right,
second.
okay.
Yeah. So just to let you
So,
know that oftentimes when
First of
you
all, I
evaluate,
must thank the organizers for inviting me. I'll talk about different techniques of brow lift and management of brow ptosis. Now, brow ptosis refers to the descent of eyebrows below its normal anatomic position. These may cause visual field obstruction, aesthetic imbalance, or functional complaints. So, surgical correction aims to restore the brow height and contour while minimizing the scars. Just a bit of applied anatomy. The brow generally follows the upper lid, the superior orbital rim. If you see the brow. I think the laser pointer is not working. The brow is slightly below the orbital rim medially, and it flares up as it goes laterally, and ends up slightly above the orbital rim on the lateral side. And the position is balanced by the elevator, the frontalis muscle, and the depressors, which are the orbicularis corrugator and the procerus muscle. There are a number of techniques described for brow ptosis, and I'll go through a few of them. You need to decide which technique is best for your patient as I go through them. The most common one is the direct brow lift, which is the classic one, and goes through the above the entire length of the eyebrow and excision of the skin and muscle. It gives you good direct control, a predictable elevation, and has a durable result. But the shortcoming is that it leaves a visible scar and might damage the nerves. Sometimes it's just the temporal part of the brow that is involved, so you can do just a temporal direct brow lift. And this hides the scar within the brow and can be combined with the upper lid blepharoplasty. So this is my patient who has a unilateral brow ptosis because of facial palsy. So I've made a temporal crescent, which I'm going to excise. And that includes the skin and the muscle itself, and go down to the periosteum of the scalp. Once you've done that, and you fixate the subcutaneous tissue with the periosteum here with the non-absorbable sutures, so that the brow keeps remains in an elevated position. So you can put in about 2 or 3 such sutures through the periosteum, one central, one lateral, and one medial. The rest of the wound is closed by subcutaneous proline suture, vital suture, sorry, and you close the skin with a continuous proline suture. The proline can be used either as interrupted sutures, or I as I prefer to use it, a continuous suture with the interlocking knots. And at the end, you can just tie the suture with the loop itself. The other type of brow lift is a gull wing direct brow lift, but this is reserved for older people because it gives a more visible scar, and but gives you it's suitable for very severe medial ptosis. Mid forehead lift is in older men who have very deep forehead frowns, and you can hide the scar in one of these natural litids. Transblepharoplasty browplexy is just used if you are afraid that the brow might move down, and you can combine it with your blepharoplasty. In younger patients who want to avoid scars at all costs, you can go on to do a endoscopic brow lift, and that is the scars are hidden behind the hairline here, and you can go through the endoscopically under the muscle and fixate the brow with either drill holes, endotine, or microplates. And then the most extensive one is if you want to do a coronal forehead and browlet lift with bilaterally, and this gives you a good lift, but you have to do an extensive dissection. You can make the incision slightly behind the hairline, and these are mostly suited for low hairline with heavy brows. Most of these complications can be avoided by meticulous technique and avoiding over dissection, which generally is a cause of nerve injuries in these patients. So at the end, I think in most of these brow ptosis patients, you need to may decide on which procedure you want to do depending on the hairline, the forehead height, and how severe is the brow ptosis. You usually aim for a slight undercorrection for a more natural look. You can use botulinum toxin to the depressors to augment the result. And endoscopic you can do for minimal scar and in younger patients. And for heavy brow ptosis, you need to use a direct brow lift. You want to avoid complications by inaccurate marking. You want to avoid asymmetry. You want to avoid over dissection, which can result in nerve injuries. You want to avoid over tight closure, which can result in necrosis of the tissues and wider scars. And also you want to avoid overcorrection in these patients. So the key takeaways are you choose the technique based on the anatomy, hairline, and patient goals. You must respect the functional and aesthetic balance. You need to have a secure fixation of the brow so that it doesn't go down after your surgery. And gentle tissue handling is crucial. And most important, as Dr. Mahmood has already mentioned, you need to counsel the patient and have realistic expectations from the patient, and avoid patients who want to get very good results. Thank you very much. Yeah.
Dr. Ihab, yeah. While Dr. Unia comes up and gets ready for the talk, yeah.
I'm wondering about the medical legal liability. Now, we're dealing with a special psychology patients, and the as oculoplastic or ocular reconstructive surgeons, we very much do what we know about the eyelid, the ptosis, and so forth. Is this okay for us to go to do an endoscopic or to do a direct surgical? And if we have an angry patient that would go after you, are you kind of covered, but your degrees and diplomas and everything?
I don't think the insurance covers that, but
but the liability. Yeah. If you have an asymmetry after doing a brow lift, hairline, or direct, and the patient is mad and he goes after you to sue you.
Mhm.
Are you protected by whatever degree you're having in ophthalmology, or is this a liability, or is this better to get a general plastic surgeon with us to cover this area as well?
If you're doing these hairline incisions and coronal dissection, then it might be better to enroll plastic surgeons as well. But if you're doing a direct brow lift or endoscopic brow lift, then you can do yourself.
Okay.
And generally, you need to again you need to counsel the patient very
Well,
extensively.
happy patient
but
will say thank you, but unhappy patient.
You can always get an asymmetrical result. Yes,
Sure.
that's true. That's true.
But
And,
who would bear the responsibility? Are we able to bear in front of the law, or it's preferable to just have somebody else?
No, I think in as far as direct brow lift is concerned,
Yes.
and that you can take, but not for the more extensive surgeries. Yes.
I think to answer the extended question, liability. You have before you walked in, we talked about how we are no longer just ophthalmologists, oculoplastic surgeons. We are oculofacial surgeons. Your liability covers what you're trained in, what you're doing on a regular basis. If you do once a year, you end up having a major complication. You're more likely to be liable. Whereas it's part of a routine armamentarium based on your previous training, and you're constantly auditing your results, presenting meetings, and that's where the labeling comes in. You're oculofacial surgeon. You are protected as oculoplastic surgeons. If you're a cataract refractive surgeon and doing a coronal brow lift or endoscopic brow lift, you may have a problem. Whereas as
but-
oculoplastic surgeons, you're trained in doing this, and you're able to protect yourself.
I agree. In our area of the world, it's so simple to accuse you of murder, but it's so difficult to say I'm innocent. This is the thing. Anybody can charge you with anything, and it's your responsibility to say I didn't do it. So the same thing. What would be your certified limit? Because we all have degrees, and
Nothing. When you
we've
do
been
trauma,
training
when
and
you do
everything.
aesthetics,
Yeah.
we start everywhere from the scalp, coronal incisions, down to the mid face. There are oculoplastic surgeons who do neck lifts.
I
They
agree.
do breast augmentation. They do abdominal liposuction,
But
including
you
fat
have
loss
to have some
training.
Yes.
Yes. Anyway, in the interest of time, we'll move on.
If you allow me, I will just make a comment that
Yes,
will be, I think, relevant for people working here.
Absolutely.
I've been dealing with the medical legal committee in Dubai for 10 years. Here, what we look at is your privileges, and the privileges are given by your head of department, your CMO, whoever. So it's not how I was trained. The liability committee don't look at that. It's your head of department. If you consider that you have the privilege to do it, he will give you the privilege. I've seen, for example, a complication case, a complaint, ENT doctor, the only privileges he has in his list, because we review the list of privileges, was blepharoplasty. So I questioned them as a liability committee chair, why this ENT doctor has only privilege as blepharoplasty, whereas the cervical surgery, etc. So no, doctor, we gave him this privilege, he does only this. And he was sued by his patient for only blepharoplasty. So we don't look at why and what happened before. So you need to have the privilege, and then, of course, as Dr. Ganga said, the training. Thank you.
So we've given the most difficult topic to Dr. Yunia Irawati. We'll keep the discussion towards the end. So we'll go on and then finish off all the talks. Dr. Yunia Irawati is going to talk to us on lower lip blepharoplasty and mid-face, if that allows.